today's webinar, we have Jason Parker and Scott Loveridge, both from Michigan State University. They've been working together on this project as part of a larger grant effort called Community Assessment and Education to Promote Behavioral Health Planning and Evaluation. And this is a really interesting research piece that examines the relationship between some of the incentives that pharmaceutical companies provide to doctors, and then there's sort of a potential linkage about a question about whether those pharmaceutical drugs are then perhaps used too much, which may have adverse impacts on the community. And so Scott and Jason will be talking a little bit about their research and the possible linkages. So I think with that, I will pass it on to Jason and Scott. If I see any chat questions for the participants, if you do have a question, you can just write that into the chat section down here. You should be able to see that on your screen. And I may, if Jason and Scott don't see that, I may interject. Otherwise, Jason and Scott, it's all yours. At the end, I'll put out a summary evaluation. So thanks a lot for everybody's participation, and thank you very much, Scott and Jason, for putting on the webinar.
Yes, thank you, Mark. So this is just a really interesting paper that we've gotten to work on, and I'll just jump right in and talk about it a bit. There we go. Of course, the project partners for this are, of course, the CAPE project, and that's funded through SAMHSA and the USDA, and obviously the regional rural development centers are where I'm headed, where I'm stationed, and so getting into things. In summary, we have, just to kind of briefly outline, we have a little bit of background work, and then I'm going to talk about the payments data, and then the outcome and control data, and then get into the methods, results, and conclusions. So, just a little bit of background. Pew Charitable Trust in 2013 published a report on pharmaceutical marketing. And basically, pharmaceutical marketing is about a $28 billion a year industry. And about over $3 billion of that goes to the consumer side. So that's marketing, that's advertising on television and things like that. Ask your doctor if you have, restless leg syndrome or whatever problem you have. You see those advertisements on TV. And that's been highly criticized. There are many people saying that that's a wrong practice, that it shouldn't be done because consumers are maybe don't have as much knowledge about the potential risks of these medications, and it's widely criticized, and it's not really what we're talking about. But the part that we're talking about is actually the $24 billion a year portion, and that's the marketing that goes straight to the doctors. And it's really kind of interesting how that works. So basically, what the marketing that we're talking about are gifts. Little gifts from pharmaceutical companies to medical doctors. These are like free lunches or dinners with other doctors discussing pharmaceuticals and continuing education programs. A lot of this marketing is they broke it up into two pieces. One part of it is what they call detailing, where pharmaceutical reps, are also called detailers, go to doctors' offices and actually present them with free lunches and handouts about the drugs that they can prescribe, free samples, textbooks, stethoscopes, and that kind of, that just general discussion. So in 2007, there was a report that said that there were about 100,000 detailers. They were actually giving out, these free samples to about 200,000 doctors. So half as many detailers as there were doctors. So they were basically, another part of this marketing is also continuing medical education programs. So there are many education programs like conferences, golf and ski resort trips and things like that, where doctors actually are paid to go on these, to these big conferences where they listen to speakers talk about pharmaceutical products and they can be paid to listen to all this discussion about pharmaceuticals, or they can be paid to actually speak about these pharmaceuticals. So there's just this giant industry that goes on about doctors trying to, about pharmaceutical companies, marketing to doctors. And kind of the worry is that these payments might condition the doctors to be more favorable, even if subconsciously, to the donor, to the pharmaceutical company. And that might create a favorable situation for the use of that company's products. So, when all this marketing goes to doctors, maybe doctors end up over-prescribing because, they're just bombarded with so much information. And it could be, even if a doctor may feel impartial, they may actually be influenced by all these pharmaceuticals. And this is kind of there have been lots of criticism. There have been a few criticisms lately of this practice. Havemeister and Bryan in 2009 proposed that doctors should have a fiduciary duty to their patients, which would prevent them from accepting these payments. But right now, doctors don't have this fiduciary duty to their patients. And kind of the question is, well, is all this marketing, having a positive effect on patient outcomes or a negative effect on patient outcomes? Continuing medical education sounds pretty great, but, obviously these pharmaceutical companies think it's worthwhile to spend a lot of money marketing to doctors, and they expect that this money should be turned around and actually, should involve more prescriptions. They clearly think that. So, what's the actual what's the actual result on patient outcomes? So, so the payments data that we have, these payments are publicly available at the payment level in 2013 with information about the form of the payment, the size of the payment, the company making the payment, and which doctor was paid. So we actually know all the payments. There are about 2.7 million payments in our data set, and we aggregate those payments to the county level and then use that to model health outcomes. So here are the pharmaceutical payments at the county level. You can see really what's happening is that so you can see around the large population centers like Los Angeles, Chicago, New York, Dallas, there are a large number of payments in each county. And, so in some places, there are very few payments, like, fewer than $100 in a particular county. But in places like Los Angeles, the numbers are really, really high. So what we did is we just said, okay, well, let's look at the pharmaceutical payments per doctor. So you can see here that once you've taken this, divided by the number of doctors in each county, it becomes a lot more widely, a lot more dispersed. So there are a few counties that stand out. Windham, Vermont, actually, pharmaceutical companies paid doctors $22,000 per doctor in Windham County, Vermont. And in Eagle County, Colorado, that number is about $17,000 per doctor. And in Los Angeles, it's $11,000 per doctor. But, obviously in some more rural places, that number is far lower. So the outcome variables that we were looking to explain were, so we said, well, what kind of outcomes do we actually have good data on? Do we actually really know about? So the outcomes we looked at were average birth weight and the rate of low weight births. So we just started to think about, well, what's something that we really have good data on, really good measurements? So birth weight is something that there's excellent data from the CDC on. Birth weight contributes to infant mortality and childhood morbidity. And the first article showing the health consequences of smoking were related to birth weight. So, birth weight is definitely a good indicator of potential problems. So birth weight is known to be affected by medications. So we thought, well, let's try to explain what's going on in birth weight and see if we can find any effect there, and then that may, imply that there could be other effects in other areas. So the controls for this, we thought we would use median household income, unemployment rates, and median age in the population. So here the number of low-weight births. Low-weight births are defined as births less than 2.5 kilograms, which is about 5.5 pounds. So that's just, how many births in that county were smaller than 5.5 pounds. And, you can see that especially in the south and in Appalachia and a little bit over in the west around New Mexico and Colorado, there are the numbers are somewhat high, and that pattern is repeated in the average birth weight, where we have far fewer counties. But so the correlation on observables between these two measures is actually negative 0.87, which is quite high. And average birth weight ranges from about 3 kilograms all the way up to about 3.5 kilograms. So the methods that we're going to use for this are just spatially corrected least squares. So the linear model is we're modeling birth weight, or number of weight births, in a linear form. We have a term for the constant, a term for payment, the natural log of payments per doctor, unemployment, natural log of household income, age, and then just a normal error. Typical spatial variance covariance matrix, because obviously county level data is spatially correlated. And so here's basically the main result of the paper. So all these numbers are significant at the 99% level. You have the actual coefficients quoted in this table, along with the standard errors, the spatial standard errors. The natural log of the payments right here is a significant number, negative 10.5229. And the same thing with the low birth weight, where you can see a positive sign there. All of these signs should make logical sense, intuitive sense. Median age might seem a little bit strange, but the reason for that is that when there are more older people in a particular county, that means that there are more healthcare services, and those more healthcare services mean that babies get, pregnant mothers have better access to medical doctors. And that's probably the reason for that. Other than that, the signs shouldn't be all that surprising. So R squared is about 0.21 for the birth weight model, and about 0.31 for the low birth weight model. And like I said, everything is significant at the 99% level. So, in conclusion, every 10% increase in dollars per doctor is correlated with a 1.5 gram decrease in the average birth weight. And every 10% increase in dollars per doctor is also correlated with a 0.0088% increase in the number of low-weight births. And that, those numbers are very small, but they're both significant, and birth weight is really connected with childhood vitality and general health outcomes throughout the childhood. So this has may have an important impact, even if the numbers are quite small. So the payments per doctor, not sure. Okay, so the payments per doctor may have effects on other health outcomes. We're still investigating the drug-induced death rate and how payments per doctor may affect opiate overdoses. Scott had a great suggestion yesterday about that. So we're still looking into that and trying to see if we can find effects in other health outcomes. And the recent changes in medical marketing laws have made it easier for drug companies to advertise to the patients. So in future years, we may see a shift away from this marketing to doctors. But for right now, it's definitely a really important part of their marketing strategy, and it's could be somewhat concerning.
I'd be curious if anybody on the line has ideas about other things that may be influenced by payments to doctors. It'd be interesting if you could type into the chat some other things that we might want to look at now that we have the basic data sets and locations put together. Also be interested in feedback from people about, let's see, this map here. Where's my pointer? There's some interesting. I always, when I get a map like this, I always want to look at breakpoints on state lines. Like, is there something happening with state policy that might be influencing these outcomes? I think a lot of these rules are kind of set at the national level, but boy, you get the border between West Virginia and Pennsylvania comes up. You can see that pretty well compared to some of the other state lines there, so curious about that. And then also down here, same thing, you start to see kind of a line there. Florida, also kind of, you've got the panhandle and most of the peninsula coming up pretty high, but then there is an area there where it's not higher than the adjoining. That might be an age thing. Where you just got a lot of people consuming medical services there, so the payments might go up. But this border here is very interesting, and so is the the border between Maine and its adjoining area. So, anybody have any thoughts about that they could enter into the chat box? Is there anything that kind of pops out about that we might want to look at as we're trying to figure out what's going on with these things?
This is Mark. Well, chat questions. I was just wondering.
Mark, you're a little quiet.
Oh, sorry. I was wondering if the what the primary reason for low birth weight is. Is it a premature birth, or so it would suggest that perhaps greater pharmaceutical disbursements might have a negative impact, but I'm wondering if you know anything about that route. That premature births? Is it just lower overall health of the baby when it is born? What do you have any idea?
Yeah, so medications I'm sure can affect different things. Could affect how the baby gets nutrients while it's how the fetus gets nutrients while it's in embryo, and how the it can, and also of course the timing of the birth. I'm sure there's an effect on both results. We didn't actually specifically look at the mechanism for this action. We're mostly just trying to see, is there an overall relationship? Because really this is the first paper that has ever taken the pharmaceutical payments and tried to line it up with health outcomes. So we didn't necessarily examine carefully the channel through which it had an effect, but it could have an effect in both of the two ways that you just.
I'm sure there would be some maybe clinical work or other studies that might add some insight on low birth weight births and the underlying causes for it. So that might be useful to look along those lines.
Is there? Oh, thank you.
I also think the idea of looking for possible linkages between pharmaceutical payments and the opiate epidemic is a really good direction. Oh, we have a comment here from Laura.
Social determinants.
Yeah, so here are the controls that we used so far was median household income in the county, unemployment rates, median age. We might be able to add racial composition of the county. Did you try that, Jason?
So I did not try racial composition of the county. That might be interesting to add. There is a paper that I'm trying to remember the name of that cited something like 30 or 40 different causes of low weight of basically of birth weights. So I think that McCormick and 1995 and Copper et al. 1993. 1985. Here we go, right up here. Those two studies reveal about 30 different potential determinants of childhood birth weight, and there are many other variables that we have at the county level that we could include. We tried not to include too many variables in this model, but it's definitely be interesting to see what could come up. That's okay. That's very interesting. Racial discrimination. Yeah, but racial breakdowns could definitely be put into this as well.
Yeah, I like that. That might improve our fit a little bit. I mean, the fit isn't bad already, but that additional control might be very helpful. Thanks for that suggestion, Laura.
Yeah. Thank you.
Yeah, I think you have some room for testing robustness a little bit more, but this is a really interesting study, and so fantastic. Thank you. Are there any other questions or comments that you might offer? I think one of the participants has had to leave, so I just wanted to make sure that the summary evaluation is available for the participants. And I think we're looking pretty good in terms of addressing any comments. Do you, Scott or Jason, do you have any other thoughts or future directions you'd like to share before we sign off for the afternoon?
No, just if anybody has thoughts about additional health outcomes that we might want to model given the data that we have already, be happy to get that suggestion. Just send it to Jason at the email address listed there.
You could use mental health days. I know you've got data on that.
So not necessarily at the county level. We have that at the state level.
Well, we're in counties, right? There's Asa Dembele has been working on some modeling that has about 2/3 of the counties. So it's not as complete as the data that we've got here, but there is county level estimates.
That's still 2,000 counties, so.
Yeah.
Is there county level data on actual proportion of people who are on any perhaps anxiety or depression medication or other types of medications?
I'm not sure if that data is there or not. I guess that we could look into that. I suspect it isn't.
So the CDC has a lot of data on the prescribing habits of doctors. Not the CDC, the AMA, American Medical Association. I know that they sell that information to pharmaceutical companies for about $20 million a year. And that data has all the prescribing habits of every doctor in the U.S. So I know that data exists.
It's just pocket change for our program here, I think. Well, okay. We appreciate you taking time to share with us your research, and if you haven't filled out the evaluation, please, we really appreciate your feedback. And if you have any other thoughts, you can send your comments to Jason, and the email is provided right here. And I think we'll sign off for now.
Thank you so much.
Thanks. Bye-bye.
Thank you. Bye.